Tell
Oh,
what
okay.
you're within a couple arms reach.
Because we're recording it. All right, so we're officially going to get started. So I don't know if you all plan to walk around a little bit, but I guess there's a mic here. So I'm going to start with some introductions. First, myself, Ashley Brooks Russell, assistant professor. I think maybe everyone but you, I know. Assistant professor in CBH and co-director of the Program for Injury Research and Education, which is Piper. And before we talk about what we're going to hear about, I would not be doing my job if I didn't promote the next seminar, which is February 26th from 12 to 1 in Ed 2 North. And it's with Lindsay Myers, who's the branch chief of the Violence and Injury Prevention Mental Health Promotion branch at CDPHE. She's a longtime collaborator of folks here. She's a wonderful friend, so we're excited to hear her talk. Injury and Violence Prevention in Colorado, Successes and Opportunities for the Public Health Field. And I'm going to start with some introductions of the two speakers, and then because it's a smaller group, if we could go around the room and say our name and affiliation with the university. And I think there might be one person on Zoom who maybe wants to stay anonymous, but
I don't think there's a
pipe
way
in or okay,
audio,
all right. So we're aware if someone's on Zoom, and yeah. So first, Dr. Becky Orsi, who's a research scientist at the Social Work Research Center. Her background includes an MS in statistics and a PhD in research methodology, both from Colorado State. And you'll learn more about her research interests, but they include child welfare outcomes for special populations such as adopted children and children with special needs. And Dr. Paula Yuma, assistant professor in the School of Social Work at Colorado State University. Prior to that, she completed a postdoc fellowship at the LBJ School of Public Affairs, is that right? At School of Social Work at UT Austin. And she studies the effects of environmental, economic, and social characteristics of neighborhoods on the health and well-being of individuals. Hopefully that's a fair description. So just for your benefit, maybe we can start. Sarah, kick us off, and we can just do introductions.
I'm Sarah Branspiegel. I work in the Department of Epidemiology and with the Program for Injury Prevention, Education, and Research, and work with Ashley on organizing seminars and other injury violence research.
My name is Jean Lee. I'm an epidemiologist. I received a dissertation award on infant partner violence during pregnancy from the National Center for Injury Prevention Control. I did my postdoc work with AAA, so I'm trained as a behavior epidemiologist with interest of injury and substance use. I'm here because my husband has been a faculty on campus, so I'm in my transition and applying for faculty positions such as the nursing research faculty position.
Hi, my name is Eliza. I work at the Centers for American Indian and Alaska Native Health, just over there on an injury prevention grant called TIPCAP. So we work with tribes across the United States on injury prevention programs. And this is my supervisor, Jen.
I am Angela Lee Nguyen. I'm trained as a psychiatric epidemiologist. I'm currently working with a program called Here Population Mental Health and Wellbeing on campus. And I'm interested in substance use prevention. I'm also working on developing a training program for ACEs, adverse childhood experiences.
I'm Carol Kaufman. I'm interim chair of the Department of Human Behavioral Health. And I'm also a part of the Centers for American Indian and Alaska Native Health, working on child and adolescent research.
Hi, I'm Jen Russell. Eliza kind of already introduced me a little bit about what we do, but we work with tribal communities on injury prevention initiatives. Right now, specifically, motor vehicle injury prevention interventions, as well as elder fall.
My name's Maya. I actually am a research assistant with the CF clinical research team at Children's. But my background, my undergrad's in social work, and so I just try and go there.
Anything with social work.
Yeah.
Well, Becky and I are great at social workers.
Oh,
That's true. We're
I
two
have a
moms.
PhD in social work, and she works at the Social Work Research Center. But I actually have an MPH, so I don't have a social work research or the social work practice degree, which is Children's Hospital for 10 years after doing my master's, and I started my love affair with injury prevention as a Safe Kids coordinator. I was a Safe Kids coordinator in Dallas and then in Austin for, I don't know, 8 years or so, and did a lot of policy work and started to realize that I wanted to do more research to answer some of the questions that we had and didn't have the skills. And so the School of Social Work at UT Austin has a bunch of public health professors in it, and that's how I ended up doing a PhD in social work. It's like training with public health people out of school of social work. Lucky me.
And I got hired out of my PhD program to work at the Social Work Research Center because I needed a statistician to deal with complex administrative data out of the child welfare system here in Colorado, the TRAILS system. And so that morphed into like a multi-year postdoc, which morphed into what I'm doing now. So I became a social child maltreatment researcher over the years.
So. I could really a statistician. She's underselling it. Anyway, that's how we ended up here. So we love social work too. They kind of have adopted us. That's right. Because they tend to be very inclusive, but we're not traditional social workers. But we were happy that they allowed us to come. So Becky and I have been working on this line of research that we're going to talk to you about for a couple of years. Maybe this has happened to you before, but we applied for a grant from the School of Public Health, our campus, CSU campus. And we're awarded a grant based on this gigantic conceptual model that we proposed to do this big structural equation modeling study. And we quickly realized that this was actually like 10 studies that we had bitten off a lot. And as we started working on the first mini study, we've been calling them, out of that big research agenda, we came across some really compelling methodological challenges, which we've been taking to our professional conferences kind of around the country and asking people for input. And so we also would ask you all for input and ideas as we kind of go through this and talk about those challenges. But we do have some cool collaborators. We've got a GIS specialist named Elizabeth Tulinowski, who's at our CSU, has a GIS center, which is cheekily been named the Centroid. She's like the center of a map. GIS Centroid at CSU, and so that's where Elizabeth works. Anita Pena is a public health faculty member as well. She's an economist. She has been serving as the chair, just stepped down from that role, of the economics department at CSU. So she's helping us with how we're trying to quantify the value of access to care. We would really like to eventually be able to talk about the fiscal benefit of it. And then Aubrey Shillington would be happy that you're here. She's also a psychological epidemiologist, am I saying that right? Which is kind of a rare thing to be. So she would be excited to get to know you. She's the chair of our department, but also public health faculty and has a public health background. So, and she kind of specializes in substance use, like you do. She's really into marijuana right now. Not personally, but professionally. Yeah. Okay. So, I mean, many of you know this, but we've been presenting this at APHA, and I just got back from the social work research meeting where we shared some of this, different format of it. You understand changing it slightly for different conferences. But anyway, as you may have heard, opioids are a very large problem in the United States right now. They're accounting for a full 2/3 of drug overdose deaths. And we know that when parents use substances, there's a higher risk for kids to be maltreated in those households. Now, most often, that takes the form of neglect. Right? Neglect is by far the most common way that child maltreatment takes place, but the risk for physical maltreatment and sexual maltreatment increases as well. And we know, if you could think about Rothenbrenner's ecological models, right? We know that these things act at an individual level and family level, in the household, but they also act from the community level. And those things act independently on kids and their families.
So child maltreatment remains a very large problem in the United States, about 4 million referrals a year, which is a lot. And we'd love to be able to intervene and prevent some of those kids from being referred to the child welfare system. So while Becky and I were sitting with our way too complicated conceptual model, the Affordable Care Act was under threat of repeal, and it's essentially now, being dismantled more piece by piece than one big dramatic repeal. But it really made us think about, we talked about needing to be able to look at access to care and how that played a role in how substance abuse would impact child maltreatment. But it really drove us to want to study it more and study it with an economist so that we could start to explain the fiscal benefit of it. So those of you who work in injury prevention probably know, some of our most effective arguments are $1 spent on a booster seat saves $37 in medical expenses. $1 spent on a DUI checkpoint saves $400 in emergency room care. Those kinds of arguments are very successful with conservative legislators. And when working in Texas, we were the 42nd state to pass the booster seat law, and it was only when we started using the fiscal benefit argument that we gained traction. So that really motivated Becky and I to start trying to look at how access to care could moderate this relationship. I don't know if this has a little pointer on it. It doesn't look like it. So how access to care can moderate this relationship. And then we also needed to look at how this varied by rurality. So we know that rural places are suffering a disproportionate burden of the drug overdose epidemic due to opioids. And child maltreatment doesn't necessarily vary by rurality, but that may be due to underreporting. So we wanted to look at how this relationship varied by rurality as well. So this is a mini study that we broke out of the giant conceptual model. And the covariates we were looking at were, socioeconomic status, single parent-led families, percent of the population in the county that was white, percent of housing that's owner-occupied versus rented, and the violent crime rate. But when we went to look at access to care, we realized we couldn't do it. So we had all these county-level variables. This is my fanciest slide, so I think we appreciate that animation. We had all these variables available to us at the county level, but there is no good county-level measure of access to care. We'll talk a little bit later about the measures that do exist and why they're faulty, but we realized this is a huge gap in what's available to us in public health. And even the big think tanks like the County Health Indicators Project that Robert Wood Johnson funds, they bring together hundreds and hundreds of variables to look at indicators of county health, and they have not figured out a way to do this. They put out a call for proposals a couple years ago, apparently to ask for somebody to develop an access to care measure, and nobody responded to the call.
Unfortunately, we learned about it after it was too late.
Right.
For us to put it.
And now we're can you please release that call again? We're ready now. So this is kind of the conceptual model for the first study we're going to talk to you about.
So I'll jump into a few more of the details and the results of this study. I'm not going to talk about this whole, we can't even see it up there, can you? Well, that's okay. I'll just talk about it. Which button am I using to go forward?
So I like the scrolly thing. If you go the other way.
There we go.
Be careful not to do too many at once.
So actually, back to the, whoops, sorry, I'm not used to it being so far away. So just back to the conceptual model again. So it's a county level study is what we did, right? And we pulled together all these different data sources at the county level from across the country. Because one of the things that we're interested in with child maltreatment is to get into those higher ecological levels. Most of the research literature is about the individual and the family risk factors. And we talk about theoretically that at the community level and even at the cultural level, Bronfenbrenner talks about,
that there are things acting that would put children at risk for maltreatment, but there's much, much less research, right, about what's going on at that community level. So this county level study, and we'll talk more about county versus other community level measures in a second here, but this is our first attempt. So all the different data sources, I'm going the wrong way. There we go. All the different data sources that we used are listed here, and we can share a copy of this later on. But just to highlight, so in terms of measuring maltreatment at the county level, we used a proprietary data source from the National Archive for Child Abuse and Neglect, which is at Cornell, and they house the data set that is a compilation of administrative data from all 50 states, the child protective systems in each of those 50 states. And actually, I don't think quite all 50 report up because it is technically voluntary, but a high number of those 50, right? So our outcome here that we're looking at is counts of unique children who are reported to an agency for maltreatment per 1,000 population annually. Unique kids per 1,000 population annually. And a report means that there was not only a call made to an agency, but that call was screened in, and so some sort of action was taken, right? Sometimes those calls result in a screen out, where there's simply not enough evidence or information that even a social worker might go out and visit the family, like it's a grieved spouse or something like that making a phone call, right? Or maybe just not enough information. So reports is what we're looking at. Those are the calls that have been screened in. Our main, I'm still going the wrong way. Our main independent variable of interest is serious substance use in the community, which we measured with a variable put together by the folks at the CDC. And so they model drug overdose rates, all types of overdose, not just opioids, at the county level for all counties across the country. And the reason that we sought this out is because, as Paula mentioned, we're interested in the moderating effects of how rural a county is, which is obviously correlated with its population. We're trying to keep as many small counties in the study as we can. So sometimes in the research literature, when you'll see a county-based study like this, some of the small counties will just have been dropped out because the rates are too unstable or what have you, or you can't get those measurements, or maybe there's privacy concerns with this sort of data at that level. So we're trying to keep as many of the small counties in as we can. And so this measure was available from the CDC, and we were able to download it at the county level and merge it together into our data set. Still doing the wrong way. And then the last one I'll highlight is how we measured rurality, as we're calling it, in 3 different categories: a metro, a non-metro, and a rural category. So metro is essentially counties of various different sizes, but in large urban areas. Non-metro would be smaller populations, roughly 2,500 to 20,000. Urban, adjacent to a metro area, but not directly in. So think Sterling or Salida in Colorado, so smaller, right, but not completely rural. And then the last category of rural would be the very rural communities with really no urban center at all. Okay, so enough about data. And the ones that I'm not talking about now are simply the covariates. So ultimately, our data came from, I think, 5 or 6 primary sources. We were able to access a lot of it through the Robert Wood Johnson County Health Rankings, which is a super resource for studies like this. So, okay. So for our analysis, we used a really fancy model, a zero-inflated negative binomial model. You really want to be able to say that and send it in to reviewers to look at. And as I mentioned, our outcome was the maltreatment report rate per 1,000 child population in the county, counts of unique children. So the reason we used this zero-inflated model was we're looking at counts, or actually rates, and we want to keep those 4% of counties in the study that had very small child populations, right, since we're interested in this question of ruralness. And so the zero-inflated model lets you have 2 different kinds of zeros in your count, right? So there's plenty of counties with 0 reported kids in fiscal year 15, which is the kind of anchor year for our data. Sometimes there's 0 because the population is just very small. We're just not going to have some. Sometimes it's a real 0, if you will. Population might be larger, but there just didn't happen to be reports that year. Now, obviously, that wouldn't happen with a very large county, but essentially there's 2 different ways that can happen, and so the model is trying to take that into account. I really just want to keep going the wrong way. Okay, so here's the results in a graphic form of what we found. So up and down the side there is the maltreatment report rate, which the mean of which is about 52 kids per 1,000 per year in the county. Hang on, I'm going to make sure I'm saying these numbers right here with my notes. Just high, right? That's high. So maltreatment is still really a serious public health issue. Across the bottom there is our main independent variable of interest, the drug overdose deaths per 100,000 in the county. That's the model variable from the CDC. And they're shown in ranges because that's the way that they are modeled. And so that modeling process that they're using is essentially helping to fill in the gaps and provide an estimate even for really small counties. So over to the left there, 0 to 2 people per 100,000, all the way to the right, over 30 deaths per 100,000 due to drug overdose. And then the colored lines, of course, are the different rural groups. So we've got the metro counties in that yellow line, the non-metro with the red line, and the rural with kind of a bluish line. Now, what we expected to see was that what we hypothesized is that metro line we figured there would be a positive relationship, and there is, not surprisingly. So more serious substance use in the county, more reports of maltreatment. We figured that metro line might be the flattest one, and then it would tip up a bit for non-metro, and it would tip way up for rural. And as you can see, that is not what happened. Because really, the yellow line is the flattest one, if you will. The most rural counties are the next steepest, and the steepest group is that non-metro group, which we found a little bit surprising, so I'll come back to that in a minute in terms of how we're trying to dig into that. And so just in terms of a couple more numbers here, I don't think you can see that, but the metro county's result is saying that the steepness of that line is saying 1.9% increase for each unit increase, 1.9% increase in maltreatment report rate for each unit increase in overdose. Rural counties is actually a 3.1% increase. Non-metro counties, the steepest group, a 3.7, almost 4% increase. So, and with the confidence intervals up there. So after we got done, and we got it all written up to get published, we had a couple big questions. One is, what's going on with the non-metro counties? And so we had a super opportunity that it kind of landed in our lap a little bit, although we also had to do a little bit of work. The folks at Extension up at CSU campus were interested in some research collaborations with the School of Social Work and other departments in our College of Health and Human Sciences, and they were looking for people who were doing kind of smallish projects that had to do with rural communities, of course, which Extension has an interest in. They also wanted to involve students. And so Paula and I said, here, we'll take your money. So we've been, we started working last summer on a series of focus groups in 3 of these non-metro communities. So they all begin with S, and I get them mixed up. We've been to Sterling, we've been to Steamboat Springs, and we've been to Salida. Convening a focus group in each place, essentially asking, tell us about providing child welfare and child protective services in your community, and also what are the challenges essentially to that, especially in relation to families that are using substances, and then what are the unique strengths that you bring, right? So as social work wannabes, we're always looking to come from a strength-based perspective, right? So what unique characteristics and strengths does that community bring? And so we don't have the results of that all yet. We're kind of, actually our graduate research assistant is like up to here in the qualitative data. But we hope to at least shed, I mean, obviously it was a national study, right? And we can only go out and visit with folks easily here in Colorado, but we're hoping to dig into that a little bit and see what's going on. And we didn't just limit it to folks who were in the child welfare agencies, but also other partner agencies, their public health folks, youth development folks, and so forth in those communities. So that's one question. And then the second question is the one that Paula alluded to, and which she'll now talk about a little bit with our maps that are up there, is how do we start thinking about measuring this access to care moderator? So if we see these results, right, could we tip those lines back down, maybe see a relationship that wasn't as strong in communities which had better access to substance use and mental health treatment? But that's kind of where we got stuck, because we thought there would be a measure out there, but there isn't. Okay. Handing it back over. Any questions so far?
Told you she was brilliant statistician. may not be a good sign, actually.
Okay, so we thought, we continue to think that part of the explanation for the relationships being stronger in the rural and non-metro areas compared to the urban areas is that people don't have good access to mental and physical health care or to substance use treatment in those communities. And we wanted to start looking into that further. We recognize the rural communities, these non-metropolitan communities, they vary so widely, right? Like, one of the places we visited, Steamboat Springs, that's a resort community, and they want for nothing in Steamboat Springs. But all the people from surrounding communities that came to that focus group had a lot to say about what they need and how difficult their work is. So there's a lot of variation even within these rural counties and communities in terms of economic resources, educated populations, how much healthcare and substance use treatment is available. There's also cultural differences in reporting. There's a human development and family studies professor at CSU who's been looking into differences in reporting by religious conservatism across the country, and finding that people are less likely to want to report in these more conservative or religious communities. And some of that might be that there's greater acceptance of physical punishment towards children, and also maybe a bigger inclination not to interfere with the way other communities operate. So that kind of culture may play a little bit of a role. We don't really know how much in these rural communities. But the fact remains that we need to be able to quantify the benefit of substance abuse and mental health treatment in interrupting this relationship, and many other relationships too. Like all of these outcomes of despair that we've been talking about in public health, child maltreatment, but also suicide. We don't know how many of these drug overdoses are intentional. There's domestic violence. There's a lot of other outcomes that this kind of study could be really useful. All right. So in this next study, we wanted to start trying to solve this problem and looking at the ways that exist to measure access to substance use and mental health care. And we thought we could kind of like look at what other people did, bring in some of those variables, and essentially solve this problem, like just line them up within our data set by county, the unique county code that we use called the FLIPS code, link data sets across counties by FLIPS code, which we provided to the county. And we thought, okay, cool, we'll just bring in some of these other measures, but we want to see what they look like on a map first, right? That was our first mistake, be careful. So the first thing we wanted to look at was drive time. So we looked at the percent of the county's population that was within an hour of first a substance use treatment provider, which is available by the Substance Abuse and Mental Health Services Administration, or a mental health provider, right? And so we, Elizabeth at the Geospatial Centroid, mapped all of these places, and we figured out what percentage of the county could get there within an hour. And then we wanted to look at it a different way, right? Because Becky and I have learned through multiple lines of research, so we need multiple measures to estimate some of these complex concepts. And so then we looked at provider to population ratios for both substance use and mental health. And we thought, like, okay, between these two things, like, one or both of these will solve our problem. Well, they don't line up well at all, right? These are the results of the drive time study. So this is access to mental health care within an hour. What percent of the population has that kind of access? I have to look at the map to remind myself. So the darker colors indicate better access to care. I'm sorry.
Yeah.
Oh, no. The darker colors indicate higher percentage of people more than an hour from care. I was like, that can't be right. West Texas would not look like that. really easy access to care. So almost everybody in a like-Lloyd County has access to care.
So it's looking at the percentage of the population that's developed, divided into quartiles. So those really dark orange ones, I think it's like 75%, so 100% of the county is over 16 minutes from a center, a mental health care center, and then, lower
it's not
portions.
quite quartiles. The lightest is like 0 to 10.
Oh, okay.
So
Can't see.
yeah, almost everyone. And then the next lightest and the light coral color is 10 to 40%. And then the next one is 40 to 75. Then the dark orange is really dark. Yeah. Almost no access.
So we thought these were going to look similar, right? The drive time versus what percentage of the population has access, right, in their county, which is the other measure right there. But you can see they don't.
And so the green map is the provider to population ratio, right? And if these were good measures, we would expect them to line up more closely. So you can see that some places have much, much higher provider to population ratios. And in this case, it's substance use treatment centers per 100,000 people by county.
Actually, I think this one's still mental health, right? Up here.
Yeah.
So
Oh, sorry.
So the dark ones are still poor access, where there's no center at all in the county. And then as you get lighter, you've essentially got more centers per 100,000 population, right, in the county. And so the dark in both places is poor access, and it doesn't look the same.
Yeah. And it's kind of hard to see that the dots are the locations of the centers.
Yeah.
So that's a little bit hard to see on this screen, but if you're interested in this, you're welcome to come look at this later, which is why we brought it with us. And then the same was true.
It doesn't. Do you want me to change slides for you?
Oh, it's okay. I'll just come over here. We found the same issue with the substance use disorder treatment. So the drive times and the provider to population ratios didn't line up as well as we expected. So we didn't feel comfortable bringing either one of these in because if we used one versus the other, we would have vastly different results in the effect of the moderating variable, right? So we would make either a stronger or weaker argument than truly exists, and would have some measurement error. Now, Becky and I have also published a study recently, which I'm sure you read in the Journal of Safety Research. Just kidding, that's a joke. Yeah. So we did a review of the last 12 studies, 12 years of studies involving measurement of socioeconomic status as it acts on an injury outcome. And we found in that review, and a previous review of another 10 years of studies had found the same thing, that you've got to have more than one measure. And ideally, not only do you have 3 to 4 measures of socioeconomic status, either in an index or that you bring together in your own analysis, but you also have individual and community level variables. So that does the best job of predicting how socioeconomic status acts on injury. And, it's just interesting that we're finding the same thing again. Like, we really need multiple measures of access to care that are both these kinds of community level indicators, and then we're also thinking a lot about the subjective individual level indicators. Like, if you go, even if you have access within an hour or there's a provider in your community, is the stigma of seeking care as a parent so high that you won't do it? Does the provider speak your language? Can you get an appointment in a timely manner? Do you have insurance? Can you pay? Do you even know how to navigate this system? And for parents, too, seeking substance use treatment, we've heard a lot in the focus groups that the amount of difficulty associated with an inpatient substance use admission is oftentimes so high that parents can't accept that care, right? Like they can't do it because who's going to take care of their children? So there's all kinds of variables around the subjective experience that we need to measure. The National Health Interview Survey asks one question. Last time you needed to seek care, were you able to get the care you needed in a timely manner? That gets at kind of the subjective experience, but it can't be used at anything smaller than a state level. So they won't even talk to you about releasing the data to you sub-state. So most of you are probably familiar with Healthy People 2020. Soonish we should have Healthy People 2030. Almost at 3030. That's too far. Healthy People 3030. They argue for a now three-part definition of access to care. It includes these subjective measures, financial access to care, as well as the physical access, being close enough. And so we'd like to eventually get to some kind of index that encompasses variables across all three of those parts. So we also wanted to warn you about something very scary. It's a really scary font called the modifiable areal unit problem, which is essentially like if you're working with a continuous variable and you cut it into categories, how you shape those categories is going to really affect your results, right? The modifiable areal unit problem is the same thing for GIS analyses. How small or large you make those communities, whether you use county boundaries or census tract level boundaries or some sort of polygon that you draw yourself, a mile radius, a 2 mile radius around something. How do you decide what that's going to be? Needs to be very well informed by other research because it vastly impacts the results. It's a little bit of what could be happening here, looking at it by county. But it's also just a problem that kind of plagues GIS research across the board on any topic. So something to be aware of.
On that line, just kind of the measurement question about that 60-minute drive. Is that an illustration of what, why not 45 minutes?
Right, it's just where we landed. Yeah. It's just, we thought, if you've got a car, an hour is probably the upper limit of what you could ever pursue. Mm-hmm. So not having access within an hour would mean it's really bad, right? That's really far. Especially we're thinking about parents with kids and mental health and substance use problems, especially in that context. That would be a severe impediment, so we kind of landed there. But yeah, even 30 minutes or 15 minutes of driving, if you don't have a car, can be a severe impairment. And there was a really amazing kind of photojournalistic analysis of this by the New York Times about what it's like to get methadone treatment in New York City and how all the methadone clinics and those that are offering the opioid substitute as well are down in the worst part of the city with the least transit access. It takes about 2.5 hours to get there from other parts of the city on the subway. And they talk about it as methadone handcuffs because you can't work. You can barely get your kids to school, leave to go get your methadone, and get back by the time the school day is over, depending on how long the line is at the clinic. So all of this is not a good measure of access to care, right? It just varies so much. But of course, if you look at New York City, it looks fine. And it is fine for a lot of people, but for a lot of people it's not. I forgot, it's not working. Just gonna set it down. Okay, so as we've talked about, GIS has a lot of limitations, and the subjective parent-patient experience element is not included in this at all. And what we do have available, and you'll see this now, maybe now that you've heard about this, you'll see this provider-to-patient ratio in studies that you read as the access to care measure. Just like you'll see median family income for socioeconomic status, but now it's not enough, right? So take that with a grain of salt. We would love, right, eventually to get down to the census tract level, because there's so much variation within these counties. Like if you think of even the county we're in, it's, what would you say, 50% extremely rural, and 30% towns, Estes Park and Fort Collins, and then whatever's left percent of like kind of in betweens. Right? So there's huge variation even within county. We'd love to get down to the tract level, but we've got to learn some really fancy stuff, like small area estimation techniques. And CDPHE is actually doing a really good job of taking some of these state and county level variables and making them available as small area estimates at the tract level. And then Becky's also starting to look at how to do that with the child maltreatment outcomes. But this is like the next kind of big area for us to move into.
The county was as small as they would give it to me from the National Data Archive for the child maltreatment reports. Like, can't go any lower than that. At least if you're me. Maybe somebody can, but I could.
But we can. Okay. So our next steps are to move towards, at least at first, county level measures that encompass some of the subjective and objective experiences a little bit better. We're starting to look at some states conduct their own survey studies, like the National Health Interview Survey question that I told you about. Some states across the country are doing their own survey that looks at health access. Colorado's one of them. So it's not the Colorado Health Foundation. It's the Colorado Health, we always do this, institute, something, that makes available some of their data that we're still learning how we can use it and how small we can get it. And then there's a few other states, Oregon, Virginia, Rhode Island, that conduct their own surveys. And so we're kind of starting to explore, can we look just at those states' data and start there? There's a cool newish resource I wanted to tell y'all about called the Distressed Communities Index. And we're going to move toward that instead of what we've been using for socioeconomic status, because it gets more at the concept of strain and how a community is changing over time in recent history. So it looks at, have more businesses opened in this community over the past 5 years? How many positions have been lost in this community over the past 5 years? It brings together several of these kinds of indicators, as well as the more traditional, like median family income, into an index so that we can better estimate socioeconomic position of a county, but really like what families are experiencing there. Not just, how much money you have doesn't really do it, because it doesn't account for cost of living or whether you'll still have a job next week, those kinds of things. And then, as we talked about, we want to look at small area estimation techniques. We want to continue using GIS because it's valuable, but we want to look at how to bring in multiple measures using that. And then continue to explore the qualitative piece of things and what it really means for parents and families, child welfare providers in these communities as they grapple with mental health and substance use. That's where we'll stop talking at you. I think we have time for discussion, questions, and any ideas you have about how to measure access to care.
Actually, that's really
are
what
welcome.
we want to know.
Yeah,
What are your ideas?
That's the only reason we came
try
back.
and move forward.
Yeah, go ahead. I just wonder if you've done any exploration of the relationship between the measures that are not matching the way we thought they would. Like, are they orthogonal?
That's a good question.
But it would suggest somebody's actually planning.
Right.
Like, there's resources here, so let's put something else there. Like, I don't know, any kind of...
We have not, but that would actually be a good idea. And I've been kind of kicking around in the back of my mind, like, we have these couple that are about geography, and we need to move into the other areas that the Healthy People framework looks at, like, cultural competence providers and insurance and stuff like that. And I've been sort of think about, like, how are we going to validate that? You know, we can put them together in a measure, but then, you know, how are we going to validate that and know if we're doing a good job? So, so thank you for that idea. That would be one thing, you know, to look at.
And how do you get at cultural? I mean, you'd have to somehow have individual level data to really get at some of that, and then when you aggregate.
So our best idea on that is something, just as an example, like Berthas, which right now is still more about percentages of different types of disease, burden, asthma, and so forth, obesity, whatnot. But that's one of the measures where our friends at CDPHE are looking at how to take that from a county level measure, use other information about a census tract, and bring it down to a reasonable estimate of the census tract level. So what I had in mind would be something where maybe even a state level measure, you know, about cultural competence. In some survey that we, like Paula was mentioning, some surveys are available only at the state level. Could we use a similar technique to bring a measure from the state level down to the county level, and then begin to incorporate it? I don't have a good answer for you yet.
Yeah. Well,
So
let me know.
that's actually, that's I think going to be the hardest piece to incorporate into the index, because I don't know that there's a lot of folks who are even asking that question at any level.
Have you thought about data at the RDC?
Yes. So I have been to a couple of, so RDC is the regional data center that the feds just opened in Boulder. And it's the first time we've had one in the Rocky Mountain region. They've got them on the east and the west coast. And that's like where they like do a whole background check on you, and you have to leave your phone outside and you walk in with your secure thumb drive, right? And you can get down to census level, individual census level responses. So I have been to a couple trainings on that. We were both at a training actually a year and a half ago when they got started. I do think that would be a good thing for us to come back to. At the time, it was kind of like we weren't far enough along to really link what our questions were with what they might have to offer, but I do think that's a possibility that we need to bring back on our radar.
Well, there are huge hoops to jump
I
through
know,
to get
and
there.
I'll be honest, like, after we
barrier.
went to that training, we thought it'll take us even like 6 months or a year to even like be able to walk in the door. So,
I think too we've been in this like exploratory kind of iterative process where we thought like, okay, we'll use one of these measures and that'll be what we need for access to care. And then we're like, oh shit, that's not gonna work, you know. And at the RDC, you've got to go in with your code already written. Like you have to know exactly what variables you want ahead of time, write that proposal. And so we just thought like eventually maybe, but it didn't fit where we were right now. To, you know, drive an hour, look at some data, go, oh, that's not going to work, drive back, drive another hour the next day. Like,
what we probably need to do is start the process of getting all the clearances so that, like, you know, we can use it.
Yeah.
And then we'll be ready for it. And it seems like a good fit. But yes, I think it's possible that could be a good resource.
It is
for us.
hard, those different levels that you work in the state level.
Right. Yeah, go ahead.
Is percent insured something that's
That's available. Yeah, we can get that from things like the American Community Survey, and there's a tool out there. Well, we have it through our library at CSU called, I think it's the Social Data Explorer. I may not quite have the name right, but it basically helps you kind of filter through all the different levels in something like the American Community Survey and get down to even a tract level. So yes, that piece actually I think won't be as, and it's definitely available for Medicaid. I think it's also available for private insurers.
But what we found is like, if we were coming to an index, that's one of the variables, right? That would have to be included. But it's such a bad indicator of access to care. Like some of the people who private pay have excellent access to care because they are not concerned with money at all. Some people who have very good insurance never access care for other reasons. So my PhD advisor, Catherine Coven, who studies socioeconomic disparities, is a health disparities scholar,
I asked her about this one time in class. It was actually the first interaction I ever had with her, and I was like super intimidated by her because she's really famous. And she was like, never use that. She's like, that is the worst. She's like, that is the worst indicator of active care. And it was also like, as the ACH changes and is in flux, like who has insurance, like somebody who had insurance yesterday might not have it today, and like that, it's just changing so rapidly. Or what it means to have catastrophic health insurance. So you check yes, you've got insurance, but it's for a car crash, right? It's for falling off a roof. It's for catastrophe only. But yeah, you're not getting your cholesterol drawn, or you're not getting the mental health screening or screen for ACEs, or nobody's checking in on your parenting or whatever, So I'm scared of using it because I feel like Catherine will come after me.
Well, we can put it in the index. I think it
belongs in the index for sure.
Go ahead.
My dissertation was on multi-level analysis of maybe 3,000 pregnant women tested within 112 census tracts in Birmingham and Alabama. So I was very lucky with those individual measures in the second trimester of pregnancy, and also census data, and also uniform crime report data. I was able to geocode the mother's address, making those casting of grouping within the census tract, and also the violent crime report case their addresses. I was able to make those violent crime rate measurement. So just that you mentioned this could maybe ideal situation. If for us to look at child maltreatment as an outcome, what's a good idea data source you want to carry on multi-level analysis in small area?
So the state has expressed support for us in theory to release tract level data. Just the state of Colorado. Nationally, we can't have it, like to protect children's anonymity.
So actually, I am thinking along those lines potentially for a next step to actually zoom back down to Colorado only, because through the relationships that I have with folks at CDHS here in Colorado, I don't literally have access to trails like I can log in, but I have access to folks who I can set up a data use agreement with to get that. So that would be the individual level, child level information, which would have some demographics with it and which would have an address that could be geocoded. So to take that sort of data and merge it together with tract level census data is definitely on my radar. It's kind of a matter, it's firstly a matter of finding funding for someone because when you go to the feds for funding, they're not always very interested in the state level study. So you really have to work hard at justifying it kind of on a methodological, level. Sometimes journals don't like state level studies either. So I'm definitely playing with that idea, and I think it's realistic given the connections that we have. I just haven't quite gotten to the right combination of people and funding, to be able to put a whole proposal together. But I think it's also, I think, a matter of learning how to, thinking through how to make that be a benefit to CDHS if I'm entering into an agreement with them, right, to provide the data then. It's not just about publishing it, but what can we hand back to them, like in particular. So, but I think it'd be doable.
Yeah.
I think it would be doable. And in some ways, it's doable for maltreatment in a way that it's not for some other outcomes because we have this administrative data system that keeps track of every child who's reported, or who's referred anyway. So, yeah.
So the County Assessment Institute, August 5th to 9th here, maybe John Pratt could have a good discussion since he's familiar with the data. I think maybe NIDA will be interested in since those healing initiative here, not many there. And but the issue is for this type of idea, you have a report of child maltreatment, those positive cases. Who are those, your population? Who would never report a child maltreatment.
Right. That's a whole nother conversation, yeah, about, I mean, exactly. How do you measure maltreatment? Because we know that the official data isn't underreport, but we have very few sources of survey data, right, where people are asked and accurately report on questions about how they parent their children, whether or not they are neglectful. Yeah. So, yeah, I mean, most of the child maltreatment literature is still based on these official reports, but it's not perfect, for sure.
I wonder if you were to come up with some sort of index measure, if you looked at all at federally qualified health centers and like numbers of really the people's distance to those. I know they can't really give data, and maybe if you were to couple it to something like people's levels of insurance, if it could all be something somewhat comprehensive.
Yeah, the federally qualified health centers are interesting because they're designed to serve people in poverty. So sometimes, like, they exist. Like, I've worked with a bunch of Brooklyn and New Jersey, big urban areas. But what does get to it a little bit more, like, from the rural perspective, are these medically underserved areas. It's a federal designation, and part of it is like when you graduate from nursing school or medical school, you'll go work there and they'll pay off your student loans. But so those places are like the biggest healthcare shortage areas, like the worst of the worst, where it's extremely difficult to get providers to go and really provide care, and there's a population who really needs it. So again, it's like it loses that gradient, but if we could couple that in an index with all the other like things, it would be a really useful tool. Yeah.
I lived in North Carolina my whole life, a couple months ago, and I worked at one of the federally qualified health centers in one of those areas, and I know that they were seeing in some clinics where women would come for treatment when they were pregnant for opioid use disorders, that up to 90% of their patients were experiencing domestic violence. And I wrote my senior thesis about the relationship between opioid overdose death and domestic violence using assault against women, expecting it to be highest in rural areas, and the graph I ended up with looked exactly like the one you showed.
Really?
Can you send us that?
It was looking,
that.
it was not nearly as robust of an analysis, largely because I was looking only at county level North Carolina, and so many of the rates and whatnot were suppressed below 10.
Right.
So I lost most of the data that y'all have, but it was a very interesting lesson, not only in the specific environment that those non-rural areas are facing, but also the protective factors that rural areas might be facing, and just how complicated rural data.
Yeah, well, thank you for saying that, because I have to say, honestly, I sometimes read, the things that come across your feed about the opioid crisis and how it's disproportionately impacting rural communities, and I think, are we sure? Have we really dug into that, or is that anecdotal? And particularly in light of what we found, I mean, clearly we are seeing differences urban versus rural, but not exactly the way you expect. So yeah, I mean, I think we're hopeful, at least for Colorado, that some of the focus group, conversations might also shed some light on, some of that and where to go next. But I'm going to leave you my card. I'm serious. I do want to read my I do want to see that graph.
I've definitely blocked out some of that experience, so it could be that my graph isn't as, exactly like this one, but that was the general lesson.
Thank you.
With that, we'll close, and thank you again for braving the weather.
Yeah, we appreciate it. You can feel free to contact us if you have other questions later or other ideas later. Yeah.
Yeah, I mostly do a lot of the I have a proposal. I went to like a thing about it. Yeah. Okay, she's 19. I did in this.
Fortunately, I'm trying.
Well, actually, the multi-level study. Okay, so the proposal that I have with them right now. Are you really ready to consider?
I am, but just with the seat, just
No, I just went to like a luncheon.
Yeah, that luncheon.
Were you there?
Yeah, exactly.
It was, I liked
So,
it. I enjoyed that.
I wrote a proposal with CDPHA and CDHA and we were proposing death records, maltreatment, betrayals records, and birth records.
Yeah.
So essentially, and we had a couple different ideas. Essentially, children who passed away, many of them have previously been reported. I think we're most interested in those who have been reported